Yeah. So, friends, I always feel that the hydro steps, whether it is a cortical cleaving hydrodissection or hydrodelineation, it's an unsung procedure in phacoemulsification. It lacks the glamour of what Uday had just shown, cutting the lenses, and what Ike is going to show about rexes in very difficult situations, or a nucleus getting chopped into multiple places. But it plays a very important role in phacoemulsification. Many a time when I have a complication and I trace back what went wrong, I often come stumble at this step, hydro steps, which was not done properly. On the other hand, there could be complications of cortical hydrodissection, particularly cortical cleaving hydrodissection. And I'm going to talk to you about a particular complication, the pupillary snap, what exactly it is, how you appreciate it, and then if you don't take precautionary measures or remedial measures, what could be the sequelae? And finally, I'll wrap up by talking about how to avoid this complication. Now, this patient was in his mid 60s. It was not a very difficult cataract and very good rexis, adequately sized, and hydrodissection is going on. I would advise you not to blink here. So as the nucleus is balloted, I let out the fluid egress occurs from the opposite pole. At this point, when the reverse migration of fluid is happening, when the hydrodissection is happening from the other side, if you see carefully here, the fluid has gone and there is a pupillary snap. At that particular moment, the pupil comes down a little bit, and you can see a little bit of deepening that happens of the posterior chamber in that area. So fortunately, I picked it up and I modified my phaco techniques. I did a phaco, and everything went off fine. So here you can see before the IOL implantation on the nasal side, there's a huge posterior capsular rent, and there's a little bit of lens matter debris on the anterior vitreous. So patient was followed up for some time, and I really couldn't figure out what went wrong here. My rexis was adequately sized. It was not a very elderly patient that the posterior capsule would be thin and compromised. I'll be showing you subsequently that I always burb the incisions. Of that anterior chamber is evacuated of the OVD to a certain extent. If I've used Helon 5, Helon GV, or Viscoat, the capsular bag is decompressed after balloting the nucleus. And none of these cases had a contraindication for hydrodissection. And what saved the day for me was I was alert and I knew a pupillary snap had occurred, and I took remedial measures. Now, this was another case. This patient had undergone vitrectomy elsewhere, had rapid opacification of the lens. About a month later, patient came to me, and I didn't have the records of the patient available with me. So when I performed a cortical cleaving hydrodissection, you see a classical pupillary snap sign. Now, this particular patient had a lot of comorbidities, so I didn't want to continue with phacoemulsification. So I converted into a small incision cataract surgery technique in this particular patient. This patient, of course, had a pre-existing factor, a predisposing factor for the PCLN to happen during cortical cleaving hydrodissection. So the pupil snap was first described by Ronald Yeo, a good friend of mine from Singapore, in a letter to editor BJO published in 1996, where he had three cases. In one of the three cases, he had hydrodissected from the side pole. This is something which you don't do at all. We teach our residents not to do hydrodissection from the side pole. And he documented that in all the three cases, pupillary snap was recognized when there was sudden reduction in the size of the pupil to the extent of 30%. And in all these cases, he had to convert to a non-phaco technique. 6 years down the line, this was again confirmed by another study from Singapore. So basically, for the youngsters here, what I'd like to tell you is, when you perform a cortical cleaving hydrodissection, fluid accumulates behind the nucleus in front of the posterior capsule. There are capsular cortical adhesions in the equator. So as the pressure builds up, either these adhesions break because you press on the nucleus, on the tip of the nucleus, and the fluid sort of comes out from the opposite area of the capsular rexis. And if that is not done, there is tremendous buildup of pressure here, and then you have a posterior capsular rent. And this is actually the genesis of a pupillary snap sign. Now, this is one case I'm going to show you where I did not diagnose that occurrence of pupillary snap in the right moment. And let's see what happened. This was again a man in his mid 50s. multi-system illness. He was on dialysis. He had received multiple injections, I think 7 or 8 injections of intravitreal bevacizumab, and it is a grade 4 cataract. I mean, this is something which we routinely do. So Rexis went off pretty uneventfully, as you see here. It is about 5 millimeters in size, and cortical cleaving hydrodissection is going to take place. I've already let out some OVD from inside the eye, so the eye is not really hard. With the Chang cannula, please don't blink. And I just took it for granted, and I did a cortical cleaving hydrodissection. I missed its sign, but what I realized was the eye had become pretty little hard. So I remembered about the publication from Singapore where too much of fluid accumulation can result in increase in intraocular pressure, iris prolapse can happen. So I thought I was doing it a similar situation. I didn't think about other causes of hardening or intraoperative hardening of the eye, like suprachoroidal hemorrhage, because the patient had absolutely no pain. And to a certain extent, when I tried to ballot the nucleus, tried to rotate the nucleus, the intraocular pressure did come down, but it was not really soft. So I just went ahead with phacoemulsification. And since it was a grade 4 cataract, I thought I'll debulk the nucleus to a certain extent and perform all the maneuvers in front of the posterior capsule. At this stage itself, I could realize that there was a nucleus tilt that was happening. And this was pretty ominous, but somehow I felt that I would be able to remove most of the nucleus from the anterior root by phacoemulsification. But I was actually, quite wrong in making that assumption. And you find here that the nucleus doesn't rotate well. So, we are dealing with a large area of posterior capsular rent. And the inevitable happens. Though you remove a big chunk of the nucleus, but I think about 25% of the nucleus dives down into the posterior segment. By that time, the patient was quite unwell. He was on dialysis. He had pulmonary edema. So I could not complete the surgery in the same sitting. So I injected a dispersive OVD into the anterior chamber. I realized that I will just mop up the anterior segment, remove the vitreous, remove as much of cortex as possible. And then the patient will be called back on another day for the posterior segment component of the surgery, where through the pars plana using a fragmentome lens fragmentation will be done. And that was my game plan. So patient came back after 3 days after having dialysis, and then by that time the eye looks very very quiet, as you will see later on. Whenever there is a PC rent, we invariably put a suture, we close the incision, main incision. At times I've also closed the side port incisions, and this is how the patient looked like on the 3rd post-op day when we are taking him up for definitive IOL implantation. So with the fragmentome, the lens matter was removed. By the time the pupil had become small, so I had to use iris hooks to see the architecture of the capsular bag, where exactly the Rexis margin is located. And I used a 3-piece hydrophobic acrylic lens, a sensor lens, which was injected into the leading haptic was injected into the ciliary sulcus. So one has to be careful here, because if the rent is large and if you don't handle the situation well, it's quite possible that the leading haptic may go through the area of the PC rent, and you will have the whole lens dislocating into the posterior segment. So that fortunately was avoided by this technique. And this is the best technique for implanting the trailing haptic. Don't try to dial it in. And patient did pretty well for a couple of months after the surgery. He is no more. So basically here, if I had diagnosed pupillary snap at the right time, I could have avoided this complication. So whenever we have eye becoming hard during surgery, in this particular case, of course, there's a capsular block syndrome and a PCRN that happened. But we must think in terms of infusion misdirection syndrome, acute intraoperative rock hard eye syndrome, suprachoroidal hemorrhage, suprachoroidal effusion. And these situations will have, the suprachoroidal hemorrhage, the intraocular pressure will be high, the patient will have pain. And if it is not a mature cataract, not an advanced cataract, what you saw here, you will see the red reflex gradually going away. And the only option that situation would be to close the incision and take up the patient after a couple of weeks, along with the posterior segment surgeon. So basically, what I'd like to tell you that, so how do we avoid it? This is again for the youngsters. Always use a plastic syringe for performing hydrodissection. I use the smallest syringe that is available. Use BSS or Oculan, that is dignocaine hydrochloride. I use either the Chang cannula or the Akahushi cannula. And you could use any 25 to 28 gauge cannula, the Rycroft cannula, which comes with the OVDs. That is also good enough. And if your rhexis is small, as you see here, at the end of the rhexis, I found my, it was quite small sized. And if I perform a cortical cleaving hydrodissection at this stage, it's quite possible that there'll be a tremendous buildup of pressure behind the nucleus, and I'll have a PC rent. So I decided to perform a two-stage rhexis at this stage itself. So make sure that you don't have a rhexis which is less than 4 millimeters, particularly when you're dealing with patients in the advanced age group or patients with a very hard cataract, particularly female patients, where the posterior capsule is likely to be thin. So I enlarged the rhexis to about 5 millimeters and went and performed a hydrodissection. So again, for the youngsters, you see the fluid wave traversing posteriorly and then stop at that stage. You decompress the capsular bag by tipping at the nucleus, this area. So there is flow of fluid, the pent-up fluid from the equatorial area comes out, and then you do a 2-point cortical cleaving hydrodissection, and then the nucleus may rotate or may not rotate. But if I've seen the fluid waves, more often than not, it is it tells you that it is a complete cortical cleaving hydrodissection that has taken place. In certain situations, the nucleus doesn't rotate, and there are maneuvers to take care of it. I'm not going to do the details. This is something I would like to really emphasize. Particularly, it is a very hard cataract, though you have a very good red reflex. But in this kind of situation, you must burp out the OVD from inside the anterior chamber, because I always use a soft shell technique. So viscoat is always there in the anterior chamber. So you need to decompress the anterior chamber, and then only you should perform a cortical cleaving hydrodissection in this kind of scenario. And make sure that there is no air bubbles. I have had situations which I have not recorded, where air bubble was injected during cortical cleaving hydrodissection, and that had resulted in trauma to the posterior capsule. And that, of course, you have to be very careful. And I cannot resist the temptation to show you this case. This is a case with capsular cortical adhesions. These are seen in the central areas, but in certain situations, they'll be located in the peripheral area. So even if you dilate the pupil, you won't see them. They'll be in the equatorial area. And I feel that if these patients come at a later stage when the cataract has advanced, they become fibrotic plaques. And Deepak Megur is going to show you some cases where these plaques are going to be managed. So here, whenever I perform a cortical cleaving hydrodissection, moment I see a lens milk, that I know that I'm dealing with adhesions in the peripheral area. So I'll be extra careful and make sure the hydrodissection proceeds very carefully, very gently, very meticulously, and very completely before I try to rotate the nucleus. This is something which I think IK had presented, published in one of the journals. This was a rhexis. I had certain difficulties. There are a lot of annoying reflexes on the nasal side, so I was not really sure what was happening. And the rhexis, I thought went up pretty well. I completed it, but when hydrodissection happens, I realized that there was a snap here. There was a weak point in the capsular rhexis margin here, and you'll see here that that particular weak point, it enlarged. So there the rhexis discontinuity, and there are two flaps. This is one flap, and this is another flap going to the periphery. So whenever you are dealing with a rhexis weakness, there's a V or there is a point in the rhexis, not as a curvilinear one. You got to be very, very careful while performing cortical cleaving hydrodissection. There are certain situations where you should not do it. Whenever you suspect a pre-existing posterior capsular rent or a weak posterior capsule, as in these situations where there's a posterior polar cataract, traumatic cataract with intraocular glass, double capsular perforation, post-vitrectomy cataracts, particularly when the cataract has progressed very rapidly immediately after the vitrectomy. So friends, what I'd like to take home points from my presentation would be, make sure that you are aware of all the contraindications for cortical cleaving hydrodissection. Don't perform this if those conditions exist. Never hydrodissect through the side port. Always burp the incision wound for the OVD to let out the OVD and decompress the anterior chamber. Decompress the capsular bag. Do not allow too much of pressure to build up within the capsular bag. Always watch out for pupillary snap. So whenever I hydrodissect, I never blink, because this thing happens within a fraction of a second. And if you miss it, and if you proceed without modifying your steps, you are in for trouble. For soft cataract, some people do hydrodelineation. I don't do it. And even if you follow the proper guidelines, these complications, which may be associated with hydrodissection, can be avoided. So this is what I wanted to talk to you about my presentation. So this is it. If anybody